Dan Schuba, and we're going to talk today about making surgery smaller, and we'll get right into it. Here are my disclosures. I don't think they're relevant. So why minimally invasive spine surgery? Well, here's a patient with a spine tumor, and this is metastatic or at least locally aggressive lung cancer, and you can see if you do this the standard way, these patients often have wound issues because of their poor nutrition and their poor healing potential. Similarly, a patient with a locally aggressive basal cell that had operated on and radiated, doing basically an en bloc resection for this, given the multiple recurrences, led to a patient having significant wound healing issues. So when you look at some of the papers that we and others have written, you see that the spinal cord, you see the surgical site infection rate can be high. In the primary non-bonies, 9, the metastatic 10, and the primary bone tumors like sacrectomy can be very high. And here's another paper showing that factors associated with infection in sacral can be very high. Look up to 39%. This we wrote years ago. More than just infections, there's also hospital admissions that are significantly high. Patients come back in to the hospital quite a bit, depending on primary metastatic tumors. So when we think about considerations, we think about the fact that they have pre-surgery radiation or chemo, they have poor bone quality, poor healing, and a hostile environment for fusion. And so we have to think about ways to treat these patients better. When I think about MIS tumors, I think about 5 different areas, as you can see here, and they're from lower to more aggressive. Here's the simplest is cement augmentation. This is the most minimally invasive, taking fractures and fixing them with either a vertebroplasty or a kyphoplasty. And this is level 1 evidence. Not this paper, but this is the classic paper for multiple myeloma, where you see multiple fractures, and you can treat them with multiple layers of cement. Otherwise, you'd be set up to do a fusion covering many levels. And here's, as I said, this is a level 1 evidence, randomized controlled trial, showing that the outcomes for patients with kyphoplasty in the setting of spinal tumors with fractures was far better than on treatment. So when we think about cement augmentation with radiation, really that's the painful met with gross instability, probably in a sicker patient, and the ideal patient is a multiple myeloma. Total resection after instrumentation, this is really the intradural or intramedullary spinal cord tumors, where you can make really cure the patient in essence, take the tumor out completely, and you can see that by doing small retractors just big enough to get the tumor out, you can actually do these patients. Here's a patient of mine with a intradural schwannoma, and we did this with a small minimally invasive retractor, and you can see this is the post-op where you see the tumor completely gone. Similarly, here's a paraspinal lesion that's really foraminal and extraforaminal. So instead of going centrally, one can go laterally with a small tube in a classic Wiltse approach and take this out again, and the patient goes home. Here's a paper by Juan Uribe doing a similar tumor, but coming from a lateral approach with a standard a procedure that comes from the side. I don't like these procedures because it makes you see the tumor first, but you can see the approach and how he got that out. Finally, there's osteomas, which can be used, small procedures to drill these out, and taking this out in a very small procedure with a VATS technique, meaning that going through the chest with a small approach. So when we think about total resection without instrumentation, that's the intradural tumor, the paraspinal tumor, maybe the osteoma. When we think about percutaneous stabilization without resection, this has really been popularized by the Memorial Sloan Kettering group, where they do short segment pedicle screw fixation, maybe with a small decompression in this area. Here's their picture from their case, where they do a small cement augmented screw, and then in the area as well. This is where we're sitting and putting in screws percutaneously, where we think it, and you can use these screws and others that have holes in them, and you can place it. Here's a patient of mine with a larger operation, but really this is the first patient ever done actually in America with cement, and here we can see placing cement and placing screws. And this helps us in cases where there's multiple sites, and we can do this as well with cement. Here's a smaller case of thyroid cancer, and instead of doing a vertebrectomy, we can get the pressure off the nerve root, where she had mechanical radiculopathy, and do a small opening with cement in the area. So percutaneous stabilization without resection is overtly unstable and radiation sensitive, or overtly unstable without spinal cord compression. Now, the total resection with instrumented fusion in a minimally invasive way is a patient like this, which has spinal cord compression, and maybe minimally invasive, one can do small retractors and do a circumferential decompression through those retractors, and even place hardware through those areas with percutaneous screws. Here's a patient, here's a case by Dean Chow showing this without taking a pure subperosseous dissection and just opening this and then doing it fascially. Similarly, people can do thoracoscopic corpectomies. There's another case showing this through the chest, and you can see the small incisions done. So total resection without instrument, with instrumented fusion, is the overtly unstable, the epidural spinal cord compression, and radiation sensitive. Finally, the partial separation surgery with instrumentation. This is the classic separation surgery where it's partial, and this was popularized in Memorial Sloan Kettering. Again, here's a patient of mine, renal cell embolized beforehand, and then a small retractor in the classic separation style, getting the screws in, getting the tumor circumferentially. And here you can see what it looked like afterwards and reconstruction of the fecal sac, and then focused radiation in that area. So the future, this is some papers from Claudio Tatsui and Larry Rines from MD Anderson using laser interstitial therapy guided by MRI. And here you see a tumor, and that ball is this vertebroplasty done before. A patient goes into the MRI scanner, and you can put a number of thermocouplers in here under guidance to heat the tumor. And here you can see the temperature, so you're following it, and then you can do everything percutaneously. And here you see the tumor on the left, but after treatment on the right with percutaneous screws. So in summary then, the different procedures for minimally invasive making big tumors smaller is the first is cement augmentation with radiation, a total resection, and then multiple areas of stabilization that are all done minimally invasively. Thank you for your attention to this, and have a great conference.